Good afternoon, all delegates. I, Dr. Rucha Rayas, welcome you to the next session of the day on lifestyle disease reversal. Before we begin, I'd like to introduce our speaker, Dr. Asawari Page ma'am. Dr. Asawari Page has completed her graduation followed by post-graduation in cardiopulmonary physiotherapy from GS Medical College and KM Hospital, Mumbai. She headed the Department of Cardiac Rehabilitation in Asian Heart Institute, Mumbai. She has worked extensively in the field of cardiac rehab since the past 12 years, with experience from hospitals around Mumbai and Pune in India, as well as internationally at Michigan, USA. She was an integral part of the core team of doctors who conducted redo CABG surgery on Dr. Manmohan Singh, the then Honorable Prime Minister of India. Currently, ma'am is consultant and director at Aloha Lifestyle Reversal Studio at Pune, India. I take pleasure in welcoming ma'am, who will be presenting on the topic lifestyle disease reversal. I request ma'am to kindly begin with her session.
Thank you, Rucha. Thank you so much. I guess let me just share the screen first. Okay. Thank you, everyone. Thank you, the organizing committee of Scientifica and Razia Madam, Rucha, everyone for inviting me for this, being as part of this Scientifica. And I'm honored, and it's my pleasure to be one of the speakers here on this forum. So today's topic is the lifestyle disease reversal. Objectives today I'm going to discuss about lifestyle diseases and its impact. Pre-diabetes is something which I'm going to actually focus on a little more. Then comes the intensive lifestyle management that we need to look into. The reversal programs which are available and which we have been conducting at Aloha. Components of those programs. Aloha model will focus on what we do at Aloha with regards to these scientific programs. Special emphasis on exercise training and VO2 max, that is cardiopulmonary exercise testing that we do at Aloha. And I have also kind of tried to list down a couple of case studies which I wanted to kind of mention here. So yes, we all know it's a global burden. It's a major risk factor for the development of type 2 diabetes and CVD. Excess of body fat commonly associated with insulin resistance. And there are various studies given in various articles about it, which depict that yes, lifestyle disease is the global burden in society. It's basically the metabolic syndrome, as we know. Elevated glucose levels, abdominal obesity, elevated blood pressure, elevated triglycerides, and reduced HDL are the components of metabolic syndrome, which need to be tackled on. Diabetes obviously is the major risk factor. So, of course, diabetes, WHO mentioned the prevalence of type 2 diabetes is growing rapidly worldwide because of the aging population, economic development, increasing urbanization, less healthy habits, reduced physical activity. There are many prospective studies also which have documented that all major CVD risk factors such as smoking, hypertension, serum cholesterols are independent contributors to CVD in patients with diabetes, such as Framingham studies we all know. Pre-diabetes is again a condition which we all need to focus on. There are so many obese individuals who are actually non-diabetic, but they do not really know that they are pre-diabetic because they never test until the time they get those symptoms. So it is always better to make sure that if a person is in a pre-diabetic phase, and that's the time when diabetes reversal actually can happen. So as we know that oral OGTT is a very commonly used test to detect if it's a pre-diabetic condition. And as you can see in the graph, anything sugar less than 140 mg per dl is normal. When you do a oral glucose tolerance test where you give uh, um, uh, uh, 75 mg of sugar, it's like a sugar load that you give, and then of course the test is conducted after every 30 minutes, 60 minutes and 120 minutes after the sugar load is given, and then there is this analysis which is done to find out if the person is a pre-diabetic. So anything less than 140 is normal. 140 to 199 means pre-diabetes, and this is the time when we have to really start on our intensive management program of nutrition, exercise, and obviously we don't want to land up in diabetes, so we have to make sure that we detect it first, and then we make sure that we have that plan of care ready. Visceral fat is the culprit, as we know. So, overweight and obesity are highly prevalent in type 2 diabetic patients with high CVD risk, and BMI and waist circumference are related to major cardiometabolic risk factors like hypertension, elevated LDL. Regarding hypertension, again, there was this study examining 12,000 adults indicated that development of this type 2 diabetes is almost 2.5 times higher in persons with hypertension than in their normotensive counterparts, suggesting that these two common chronic conditions frequently coexist. So visceral fat is the culprit, and we all know that it is the toughest to deal with. So this is something we have to sorry. So what do we do? So it needs an intensive lifestyle management. It needs an aggressive lifestyle management. So the goal is to achieve and maintain more than 5% weight loss through calorie restrictions and increased physical activity. So there was this journal where I found that it highlighted that increased physical activity and improvements in diet can safely lead to weight loss and reduced requirements for medications to control CVD risk factors. I'm sure, I know it's an established fact now that diabetes, a person in diabetes in less than 5 years uh, is what we are aiming at, and a person if he is in less than 5 years of diabetes, it can be reversed with an intensive and aggressive management, including the various components which I'm going to talk about, which need to be taken care of. And it is not just exercise, it is not just diet, it is a holistic approach toward the patient. It's a coordination, it's a teamwork between various multidisciplinary clinicians, and that is how you get to the result of it. So these are the lifestyle disease reversal programs, and as I was saying, of course there are various components of it. We all know healthy eating, physical activity, managing stress again is equally important. Behavioral uh, management is also equally important. So lifestyle medicine, as you can see, is an evidence based approach to preventing, treating, and even reversing diseases by replacing unhealthy behaviors with positive ones, such as eating healthfully, being physically active, managing stress, avoiding risky substance abuse, adequate sleep, and having a strong support system. Uh, this is the chart that you can see. This is the flyer that we have it at Aloha, where we have this diabetes reversal program. And as you can see, the recommendations for this reversal is patients having type 2 diabetes, which is newly detected, less than 5 years since the diagnosis, BMI of more than 27 kgs per meter square. So people who are not recommended for reversal, of course they of course it is definitely all these components are helpful in managing diabetes, but when we say pre-diabetes and diabetes reversal, then these are the people whom we cannot really label as diabetes reversal, and we go into a diabetic management program. So when we talk about nutrition, of course, the principles of current nutritional recommendations for individuals include individualized modification of macronutrient intake to accommodate individual needs. And there are various types of nutritional guidance which are given depending on how the parameters are. But something which I really wanted to focus today was on Mediterranean diet. It's a low fat monitored carbohydrate diet. And basically in 1993, the Harvard School of Public Health and the European Office of World Health Organization introduced this Mediterranean pyramid, more of an eating pattern rather than a structured diet plan. The pyramid emphasized on certain foods that you can see on in this pyramid. So mainly it is about fruits and vegetables, beans, nuts, whole grains, fish, olive oil, small amounts of dairy contribute to the healthy benefits. The pyramid also highlighted the daily exercise or daily activities, obviously, but it is primarily plant-based eating pattern, and proportion of food is more veggies, fruits, and less dairy. So emphasis is on olive oil, fish, walnuts, because it is high in omega-3 fatty acids. So fish is the main animal protein that is used, which is twice a week. Poultry and eggs in smaller quantities. But again, the effects of Mediterranean diet is there are articles saying it is 30% reduced risk of CVD events. And there is a large, strong, and consistent body of available prospective evidence to support the benefits of Mediterranean diet on cardiovascular health. Stress management, obviously, we cannot ignore it. We cannot deny the fact that stress management has to be an integral part of the programs that we conduct. And psychosocial factors like loneliness, isolation, depression, anger need to be equally addressed. Research has shown emotional and social health is associated with a reduced risk of diseases and premature deaths. In fact, there is this article given in the Journal of American College of Cardiology 2006-2015, which says mental stress provokes ischemia in CAD. And they concluded saying mental stress may produce ischemia in some subjects with CAD, and negative exercise or chemical or nuclear stress test results. So it is obviously, we all know that stress management has to be, stress management and behavioral or relationship management has to be an integral part of any program. So, so these are the group activities which we conduct at Aloha. Meditation, Omkar recitation, deep breathing and pranayam, yoga classes, group discussions. We also had conducted a painting kind of a competition which helped us to one of the stress management techniques. So, what is the Aloha model? What we do is we extensively do a counseling and education of patients and family members when a person has to be enrolled in a program. So enrollment in one of the reversal programs is done. In-depth evaluation and risk factor stratification is done by a physician. So we have a physician, diabetologist, and a cardiologist on board, everything under one roof. We also have a medical gym where we have a telemetry based cardiac rehab center. We have the Ergoline technology which we use for monitoring. And so before all that, we do a body composition and body mass analysis. A cardiology screen is done, which is extremely essential. So it is a very, obviously it's an integral part of a program where you need to have a 2D echo to know what's the ejection fraction, so that we know if we need to have a low EF protocol. We need to know what's the functioning of the valves. So 2D echo is essential, ECG is done. We do, the photographs shows the CPET, that is the cardiopulmonary exercise testing. We do a VO2 max in every individual who is enrolling for the program. So this is the one on treadmill, but we also have it on a bike. So a mask given, obviously, and the gas analysis is done. And there are various parameters which are seen, but especially the AT, aerobic threshold, anaerobic thresholds, VT1, VT2, METs achieved, and many such values which are analyzed by our cardiologist first. An exercise prescription is generated accordingly depending on, so a physiotherapist and a cardiologist sits together and a prescription is generated. A nutritional assessment is done by a nutritionist, and a diet plan is charted according to the individual's needs. And of course, we have a psychologist who performs a behavioral assessment and determines the stress score and coping strategies. They are educated accordingly. When we talk about exercise training, yes, it needs to be a major part of our rehab programs, we know, and I'm going to talk majorly on that. So exercise training we have it on Argoline system, as I said. So all are assessed for the presence and extent of the modifiable risk factors, including smoking, physical inactivity, sitting time, obesity, dietary pattern, psychosocial dysfunction, hypertension, diabetes, so their sugar levels, their blood pressure levels, their lipid profiles, everything is assessed. There is a chart maintained in our software. Then of course there is an exercise prescription which is generated depending on how the person performs on a CPET. The max load that is achieved is usually noted down, and the intensity is started mostly at 50% of the max load. Now, depending on the person's condition, we start on either a low intensity interval training or directly on a constant workload of 50 to 60%, depending on the person's fitness level, the ejection fraction, the medical conditions, the comorbidities. And then that's how a cardio workout is started on one of the Ergoline system bikes. So we start with a low intensity, as you can see that written there. And then slowly we go on to a high intensity interval training. So basically it's all load based training. As we know, there are so many disadvantages of heart rate based training, and most of the patients coming for cardiac rehab are on beta blockers. So that it makes no sense to base any of the programs depending on the heart rate. So what we do is we have a load based training, and yes, Borg scale. So of course we educate the person on using Borg scale and even a talk test for that matter. And that's how we go ahead with it. A training load is usually kept below the 80 load to start with. So this is the video which I wanted to show. So these are the ECGs. It basically the leads are we can set the lead which we want to, and you can see there is this training done. You can even have a continuously running screen. You can have a continuously running screen where you can see the ECG going. I have also tried to click on the other one. Will be seen shortly. So this is the training module, right, where we can set our training if we want an interval training or if we want yes, so this is what I wanted to mention. So the training can be set here, whether we want a constant workload or whether we want an interval training. Depending on that, as you can see, the loads can be set. The load achieved on a CPET, as I was mentioning, usually we start with a 50% of that load. So if a person has achieved, say, 100 watts on a VO2 max, then we start with 50 watts to start with, and with either a constant workload or an interval training, depending on what we want, as I mentioned. It also has a heart rate control mode, which I feel is an excellent mode for people, especially with pacemakers, where we want them to stay in certain heart rate range. So if I put it in the software that XYZ person does not need to exceed below above, say, 120 beats per minute, the load would be adjusted accordingly and the heart rate stays in that range. So I feel the technology is beautiful to monitor strictly, to make sure that the person is doing exercises in his own capacity, at least exercising in 60 to 80% of the capacity which he's needing to, and also in a safe range, which is important. There are various safety alarms which are given, which make sure that even if there is a doctor around, the technology is supporting to make sure the person is in safe range. So as you can see, there is this interval training heart rate control mode. and you can set up your warm-up time, your training time, and your recovery time depending on how you want. There is also a blood pressure monitoring, as you can see. I can actually put a blood pressure monitoring there. See, if I put in every 3 minutes, every 4 minutes, I would keep getting the blood pressure, and the entire data is saved. So it's a beautiful way to actually save the data, analyze it, and use it for research purposes as well. Right. So this was the paper which we had recently published. A kind of there was a poster presentation because it was COVID, so um, we had to do a paper presentation, a poster presentation there at AACBPR. But it got accepted that CPET has been shown to be useful in the topic was that CPET has been shown to be useful in exercise prescription and prognostication of cardiac patients for intensive cardiac rehab. And we are studying the usefulness of CPET guided CR in post ACS patients. So whatever patients we had at that time, we kind of analyzed the data pre and post rehab. The usual rehab program lasts for about 3 months. That is mostly 36 sessions of exercises, and the rest of the other sessions of diet and psychology and cardiology consults and the diabetology consults. So that's the program that it comprises of. And we had done a CPET pre and post, um, and we had analyzed almost 1920 patients at that time, which concluded that patients post ACS show significant improvement in functional capacity and cardiac circulatory markers in CPET after intensive exercise-based cardiac rehab. So we wanted to objectively show that it is an important tool to assess the cardiovascular circulatory status and usefulness of cardiac rehab. Right. So these were as you can see, these were the parameters which we monitored. That the mean left ventricular ejection fraction we had taken for all the individuals, and from the CPET, which can show total load, the peak oxygen uptake, the percentage of predicted PVO2, minute ventilation to CO2, so VEV CO2 slope, the O2 pulse, even the heart rate max at peak and VO2 work slope. So these were the numbers which we had compared pre and post of the CPET. So it's an excellent tool for us to objectively measure a person's functional capacity pre and post for all the systems for that matter, because we need to do a pulmonary function test prior. So we do a PFT first and then an exercise test is started. So we get PFT values and we also get these Wasserman's equations of CPET, which we can see. So this is one of the case study which I wanted to mention. This lady was a 32-year-old female IT professional. She wanted to get married in 5 months. Came to Aloha. She was weighing 110 kgs, BMI of 38, a fasting sugar of 152. Imagine she was just 32-year-old, but since being an IT professional, and I guess it was not really during the COVID, but a little before that maybe, because of the IT profession and kind of a work from home kind of an occupation, she used to be at home sitting and working. HbA1c 8%, 38 inches of waist. In about 3 to 4 months of the program, she lost 15 kgs. She was actually started on metformin. That is also one thing which I forgot to mention. But she was on the BP medications. I think within 6 months, but not much. So she had come to us for diabetes reversal, and with the entire diabetes reversal structured program of exercises, diet, and the stress management counseling sessions which she had, and complete monitoring. She lost about 15 kgs. So after 4 months, she was 95 kgs. Her BMI was 30. Her fasting sugars were 90 pp, 115. HbA1c came down to 5.8. The waist came down, so she had a lot of inch loss. It was 34 inches then. And the most important factor was her metformin was stopped. And now uh, we've been following her up because now she got married and she's almost 3-4 months after her marriage. She's still maintaining this entire lifestyle and she's off medicines. Just one more about cardiac reversal also. The technology helps us because there are a lot of things which you can actually see and monitor on the screen, and that's how you can kind of be confident about what you're doing and confident about what exercises you're giving. So this was a 70-year-old male diagnosed for TBD and it was advised CABG. He had dyspnea on exertion after 5 minutes of walk. He couldn't climb stairs. He was not willing for surgery and he came to Aloha and started on a cardiac reversal program. Of course, um, uh, um, he had no major goals of, there are people who come to us and they say, oh, I want to go on a hill or I want to start cycling. But this gentleman had very ordinary and routine goals of he wanted to get back to his normal routine of day-to-day activities comfortably. That's all that he wanted to do, and he was not willing for a surgery. So he started on a cardiac reversal program, including aggressive medical management. Of course, it is the most important thing. Graded exercise training, nutritional and psychological counseling sessions. And 4 months later, I have also in my next slide shown the ECG of this person. So we started on a 40 watts on ergoline bike. Of course, we did a test and then we symptom limited test. So Met's value was 3.3, and he obviously had ST changes of depression. I'll quickly show that later. But about say in 4 months of extensive medical management and exercise and nutrition, now he is still coming to us. Must be his 5th month or so. But at 90 watts, he is doing 6.2 METs activity with no ST changes. So when we say cardiac reversal, I think one of the concepts of it is ischemic preconditioning. So it's an intrinsic process whereby repeated short episodes of ischemia protect the pericardium against subsequent ischemic insults. So if you can see, the left one is the one which showed the ECG changes of ST depression when he was on 40 watts. And now 4 months later, you can see this ECG where he is doing his exercise on a bike at 90 watts and still no ECG changes. And he's comfortably doing all his activities. We also take a health related questionnaire pre and post. So we do an SF12 pre and post, and which also showed significant improvements. Now he can actually climb up and down 2 to 3 floors where he lives comfortably with a very light intensity on Borg scale. So this is the exercise based cardiac rehab training, which you can actually look at the difference in the ECG. These are certain activities which I briefly wanted to just mention. We do a lot of walkathons because these are something which we really need to work on promoting we physios as a profession, and we have to make sure that we spread this awareness amongst the community. So we got to do a lot of these community talks, community educational camps. We also do a lot of in-house activities, obviously, to promote these educational programs. So yeah, exercise has to be a lifestyle change. So we all have to start exercising, huh? Thank you very much. I think that is all that I wanted to mention in the given time, I guess.
Ma'am, could you stop sharing your screen, please?
Yes, I will.
Thank you, ma'am, for the informative talk. It was indeed interesting to learn about the kind of practices that you have at your setup. And I think out of all of this, which I found very prominent, was that when it comes to exercise, there's this big problem with patients being motivated enough, but then we talk about goal setting. And you mentioned things like losing weight, fat reduction, agreed, but something like going off medications, it's a big deal. So that is, I think, a goal that, a lot of patients will definitely be motivated because of.
Correct.
I have a few questions for you. My first question
Yes.
is, if a physiotherapist wishes to set up a small budget lifestyle disease reversal clinic,
Mm-hmm.
how would you suggest that they go about it?
Okay, I think I'm sure this Argoline system is a little. Of course, you will have to really look at your finances when you go to Argoline. But when you want to have a small setup of lifestyle disease reversal, then I'm sure we need to have all those components in place, as I was mentioning. So for exercise, we need to have a small setup of a gym where you can have a cardio workout on either a bike or a treadmill. You need to at least have a telemetry, so you can at least, if not have a software control, but at least you should be able to see what's happening. So that is one thing. uh, you need to have a resistance training equipments, obviously. You need to have people who are trained for emergency services, because you need to be at least a BLS certified person, if not advanced ATLS, but at least a BLS certified person, because you need to have a backup. Cardiac rehab facility, that's the reason, is usually a hospital based facility because it needs a backup. So you need to make sure that you have emergency setups. You Because it is something which is very crucial. You're dealing with all high risk individuals, so you need to have an emergency setup. Of course, yes, you need to have a nutritionist and counselor also on board, because that is also an integral part of it. And yes, if you have connections with the physicians and the cardiologist nearby, then yes, I guess that should work.
Okay. So monitoring, I think, is of utmost importance here.
Right,
As you
right.
mentioned, telemetry.
Yeah, yeah.
Okay. Now we know, I mean, based on textbooks, we know about what kind of risk factors, age, gender, but nowadays in recent times, we are coming across a lot of young individuals, facing similar conditions. So have you come across in your patients any new kind of risk factors apart from the usual ones that we look for?
Okay. So, of course, we have a lot of people nowadays at 30, 35-year old coming for reversal programs. But we also have a 14-year-old girl. She's a Turner syndrome. She's a hypothyroid, hypertensive, hypothyroid. She's got, of course, menstrual disturbances because she has no ovaries, because she's Turner's. But if you see her, of course, she's obese. So that was a challenging case, because syndromic kids are usually very tough to deal with. Uh, if you see her, you will not notice that there is anything wrong in her. In the sense, the features are fine. She's absolutely a normal 14-year-old kid, but a lot of medical issues. So we had a lot of challenge dealing with her. But of course, yes, I'm proud to say that 4 5 months down the line now, her eco findings are good. She has lost almost 6 kgs, which was tough to deal with, because syndromic kids usually take a longer time to lose weight, because of multiple factors there. So she took a little longer to lose weight, but once she started to, yes, she started to lose weight. And all the other rest of the parameters also came quite okay, because she started being more active. Her mom is happy, her family is happy. Her weight is reduced, visceral fat is gone. All that is fine. But the most important part of it is that her BP medicines have gone down. Even her thyroid levels are under control. So that was one challenging thing which I thought would mention quickly, spontaneously, when you asked me.
Okay. Just one last question for you. You spoke about calorie restriction and increase in physical activity. So we
Mm-hmm.
are basically trying to, focus on losing weight here, right? So, how do you quantify physical activity levels? Because when it comes to calories, we know that, okay, we have charts to refer to that this food item gives me these many calories. But a lot of us still struggle with the other part of it, physical
Right,
activity. How do we quantify it? What kind
right,
of tools would you suggest can be
right,
used?
right. So actually, it is very easy because of this ergoline system. Uh, uh, the ergoline system, after the training is done, shows how many calories are burned. So we get to know that these are the calories which the person has, burnt in this today's session. So that actually helps us to monitor it well.
Okay.
Yeah.
But any other tool that you recommend that a therapist could use to quantify?
Otherwise, there are gadgets nowadays to see. So there are gadgets to see if you want to really see that these are the calories I burnt in this session. And I think there are gadgets nowadays to check if how many calories you have burnt.
Okay.
Ah,
Great. It was nice having you with us today. It was a very informative talk. I'm sure our delegates also had a lot of new things to learn. So I'm very happy to have moderated this session today.
thank you, Rucha.
Thank you for joining us at Scientifica 2021.
Thank you very much.